Life-sustaining treatment notes, the why behind the plan. Serious illness requires longitudinal planning. Illnesses such as progressive cancers, advanced organ failures, neurodegenerative disease, and the medical frailty associated with aging naturally lead to life-threatening conditions. This means several years of worsening health status. Patients have frequent hospitalizations, but they're the same person underneath with similar goals and aspirations. We should not start planning from scratch with each new exacerbation. Instead, the life-sustaining treatment note carries the patient's longitudinal plan from one encounter to the next. Only people with serious illness are required by VA policy to have a life-sustaining treatment note. People who don't have a serious illness but who wish to limit life-sustaining treatments should also have an LST note. Life-sustaining treatment notes provide the rationale for treatment choices made in advance. It's a short note with just enough information for other clinicians to understand the basis for treatment choices. It's thoughtfully prepared and clear enough so that other clinicians, often in stressful circumstances such as a code or an RRT, are able to understand the goals and trust the plan. Life-sustaining treatment notes are intended to be rewritten over time as the patient's illness progresses and their options and goals change. Early in illness, people may be willing to undergo more aggressive treatment. As the illness worsens, they may want to limit treatments because they're less likely to restore function. Life-sustaining treatment notes should be reviewed regularly, but only rewritten when changes in the medical condition or the patient's goals warrant changing the associated orders. Existing life-sustaining treatment notes should be reviewed prior to evaluating the patient. They're easy to find. They can be found by looking in the posting section. The posting section indicates that there's something important on the chart. If there's a C in the posting section, you can click on that and it will reveal a text box like this. Select the most recent life-sustaining note. If there's more than one, always check the most recent one. If there's no existing life-sustaining treatment note or the patient's situation or goals have changed, you'll need to begin a new note. To open a new life-sustaining treatment note, you'll go to the Notes tab and start New Note. If you need to search for it, type in LIFE hyphen. That way you'll make sure you get to the right note first. If you leave the hyphen off, it's easy to click the wrong note. So just remember the hyphen and you'll end up in the right place. Starting a new note will bring up a template that includes reviewing prior notes, capacity, surrogacy, the medical situation, patient goals, plans, consent, etc. The top of the template reviews who needs a life-sustaining treatment note and then brings you to two buttons that, when clicked, provide the prior life-sustaining treatment note or advanced directives. It's very useful to utilize these within the note because when you pull it up, you can copy and paste elements of the note that are still relevant to the current note, saving you time and preserving prior work. The first question involves capacity. It's important to remember that capacity means more than being alert and oriented times 3. Capacity for informed consent relies on 4 criteria: the ability to indicate choice, the understanding of the medical information provided, being able to describe the consequence of treatment choices, and to be able to reason through decisions. Why does a patient want one treatment over another, or treatment versus no treatment? Patients who are not able to make these criteria are considered to have impaired or no capacity, and they require a surrogate decision maker, or at least the assistance of a surrogate decision maker. There are some patients who lack capacity and have no surrogate. When this is the case, an ethics consult should be obtained. We'll make medical recommendations to the ethics committee, and the decisions will be made from that point. Question 2 addresses surrogate decision makers. Surrogates are alternative decision makers for people who lack capacity. If a patient wants a specific person to make their decisions, they must complete a power of attorney appointing that person their healthcare agent while they still have decision-making capacity. Without a power of attorney form or a court-appointed guardian, we must use the surrogacy rank established by VA policy. It's very important to explain this to veterans who have complex family situations. For example, if a person is estranged from their spouse but is not divorced, that spouse still has the legal authority to make decisions even if other relatives are present. Sometimes veterans are surprised that they simply can't tell us that they want their daughter or their son, as opposed to their estranged spouse, to be their decision maker. But we cannot accept an oral directive like this. It needs to be in writing. So please encourage them to complete a power of attorney so the person who is best able to advocate for them is the one who has the legal authority. Here's the template for capacity and surrogacy. Capacity is self-explanatory. When you get to the surrogate question, you'll click on the person who has the legal authority to make decisions for the patient, and it'll give you a dialog box that allows you to put in that person's name and contact information. Question 3 addresses the patient's understanding of the illness. Remember that patients cannot make an informed decision regarding a treatment unless they fully understand their illness and its illness trajectory. This section should include a brief summary that will help future providers understand the rationale for the decisions that follow on this note. And it provides them a baseline to evaluate changes in clinical status that may have happened since this note was written. For example, this patient has advanced heart failure with symptoms at rest, CKD3, moderate dementia, hospitalized 3 times in the last 4 months. Patient understands that these are all progressive and will lead to further complications and hospitalizations. Alternatively, the second example says that the patient has stage 3B lung cancer that was resected and irradiated and is on treatment. The disease is currently stable, but the patient is optimistic that it will not progress further. This may or may not be the case, but it gives future physicians an idea of what the patient understands at the time this note was written. Remember that you may be able to copy some of this from a previous LST note. Question 4 addresses veterans' goals and values. But remember, goals and values are always determined in the context of the medical reality established in Question 3. We should discuss what's important to the veteran in terms of their quality of life, their functional status, independence, living longer, cognitive status, and place of death. The difference between a goal and a wish is that wishes can be fantasies, whereas goals are realistic and achievable. Healthcare providers should help patients understand when their goals are not realistic within available medical treatment and help them select goals that are more realistic and achievable for them. The template for goals and values is a simple text box, and the summary is recorded here. Again, some of this may be copied from prior notes if appropriate. Now that the medical situation and the patient values are understood, a plan for using life-sustaining treatments that are appropriate given the situation and values can be constructed. The first question regards code status. Remember that code status only applies when a patient's in cardiopulmonary arrest and does not limit any other treatment. It's completely consistent for a patient to be DNR, but to have very aggressive treatments up until the point of cardiopulmonary arrest. There are 3 options. The first is that the patient is full code. This does not generate an order because all patients are full code unless they have an order to the contrary, a DNR order. The second option generates the DNR order. Do not attempt resuscitation. The third choice is DNR with exceptions. This is for patients who are generally DNR but are undergoing a procedure that has a heightened risk for cardiopulmonary arrest. For example, a patient who's undergoing dialysis or a patient who has a specific intervention or surgery planned may use this option. DNR with exception is quite common and should be explored with patients when filling out this question. Section 5B contains all of the life-sustaining treatments that are used outside of a cardiac arrest. Remember that many people do not want to extend life at all costs. When we use this section, we're allowing them to say, if I get this sick, I understand that I will die, and that's okay. These choices can be tailored to the specific patient's illness. You do not need to review them all, but you should review the ones that might be anticipated given the kind of illness that they have. The options we have available are mechanical ventilation, artificial nutrition, artificial hydration, blood products, dialysis, and transfer between units. If there are treatments that the patient does not want in addition to these, you would record it under other orders, and if there's any supplemental information that's helpful, it can be added under the last option, additional information. Because mechanical ventilation is the most common, we will cover it in detail. Remember that this order only applies to emergent or life-sustaining use of mechanical ventilation. It does not impact elective intubation for a procedure or surgery that the patient is able to consent for. So just because a patient is DNI does not mean they can't go to surgery for a planned or elective surgery. Let's go through a couple of cases so that we understand the difference between these choices. Case number 1. A patient with significant heart disease needs surgery for a bowel obstruction. They are at high risk for prolonged respiratory failure, but they need to have the surgery. They're aware that if they can't be extubated after a few days, they would prefer to transition to comfort care rather than continue long-term ventilation. This person would use option 4, which gives us the opportunity to say no ventilation except as specified, and then enter the specific plan for the short-term trial of ventilation. Another example is a patient with late-stage lung cancer. They don't want any form of mechanical ventilation if they have respiratory distress or respiratory failure because their illness is severe enough, or they feel that the future of their illness is such that they would not want to live to experience it. They would pick the first choice, no invasive or non-invasive ventilation. The third example is a patient with a stage 4 heart failure that's been difficult to diurese. You tell him that if he's intubated, he might not get off of the ventilator. He says that he's willing to take that risk and have his surrogate make decisions if he's unable to make his own decisions. For him, you would document the fifth choice, which is that you've discussed it with the patient and they do not want to limit ventilation at this time. All of the other treatments follow the same basic format. The one that you might want to make note of is limiting other life-sustaining treatments as specified. There are a few patients, particularly those who are experiencing long degenerative disorders, whose most likely life-threatening condition is going to be an infection. For those people, they may prefer to die as a result of their infection rather than treat it and prolong their life with a quality of life that they are not comfortable with. For these people, we would limit antibiotics, and you would note that under this section. Now that the context and the plan has been recorded, we can move on to consent. Question 6 allows us to note who actually gave consent to put these orders on the chart. Number 7 gives us the opportunity to document state-authorized portable orders, which will allow the patient to take a paper form of this out into the community. Question 8 details who's present for the goals of care conversation. It's important to remember that these conversations happen over an extended period of time, so it's useful for family members to know who might have been present for a previous conversation when they might be caught surprised by the decisions that have been made. You can also put the members of the medical and nursing team who were involved in the conversation as well, so there's a good record of who was there. It's useful to include people's specific names and their relationship to the patient, rather than simply saying his brother or his uncle. That concludes the life-sustaining treatment discussion note. Remember that by taking time to construct a careful, thoughtful, and clear note, we can help provide patient-oriented, goal-focused medical treatment for our veterans.